era muy discutida. Ustedes ven allí que el cráneo muestra un trazo de fractura, por lo tanto la cosa no es tan sencilla desde ese punto de vista. Para terminar, en homenaje nada menos que a los 250 años de la muerte, perdón, del nacimiento del gran Ludwig van Beethoven, voy a tocar un fragmento del adagio de la sonata patética arreglada para guitarra.
आप यहीं रहो ना 10 मिनट, फिर स्टार्ट के टाइम पे कर देना ना यहाँ पे।
Gracias, doctor Córdoba, por este maravilloso regalo que usted nos entrega. Y esta sección que lamentablemente, efectivamente, para un congreso completo. Vamos a continuar con el programa, la sesión que corresponde a nuevos proyectos. Está en la presidencia del doctor Antonio de los Santos de Argentina, el doctor Augusto Müller de Uruguay, y la la doctora Christine Lenz, de Bélgica, Bolivia. El doctor Antonio de los Santos es profesor titular del Departamento de Medicina de la Universidad de Buenos Aires, fue jefe del mismo, actualmente es académico el número de la Academia Nacional de Medicina de la Argentina, en el sitial del doctor Osvaldo Lodé, sitial 16. Y además ha sido secretario general de la Academia Nacional de Medicina de la Argentina. El doctor Müller Gras Augusto, cirujano y emergenciólogo, fue profesor del Departamento de Emergencias del Hospital Las Clínicas, es actualmente también miembro titular de la Academia Nacional de Medicina del Uruguay y fue presidente de la Sociedad de Cirugía del Uruguay. La profesora Christine Lenz es doctoral en atención primaria de la salud centrada en la persona del Departamento de Salud Pública y Atención Primaria de la Facultad de Medicina de la Kent University en Bélgica. Y van a estar en la relatoría distinguidos estudiantes de la Universidad de la Empresa en Colonia, la señora Martínez, la señorita Camila Baldi, de la carrera de abogacía de la U de Colonia, en Sacramento, y la señorita Andrea Tuset de Uruguay, quien además tiene, no solamente es estudiante de ciencias clínicas, sino ya tiene incluso matemática y ciencias experimentales, lo cual muestra la diversidad y la amplia gama de relaciones que tienen las humanidades también como nosotros. Adelante, doctor Antonio de los Santos, en la presidencia de esta sección. Doctor Antonio de los Santos, micro, por favor. Doctor de los Santos, no lo escuchamos, su micro está inactivo. En la parte inferior de tu visor hay un micro, ahí hay que apretar. No lo escuchamos, doctor de los Santos. Ahora sí.
Ahora se abrió. Ahora somos esclavos de tecnología. Les decía que, ante todo, deseo agradecer la posibilidad de coordinar esta mesa con tan distinguidos miembros de la comunidad médica uruguaya, que viene de la Universidad de Gante, pero tiene una aproximación a Latinoamérica de su trabajo en Bolivia. Y digo que es una tarea dura la mía, porque tenemos que bajar de la belleza de la música y del repaso de biografías tan ilustres, Mozart, Beethoven, Brahms, y tener que bajar al duro terreno de la educación médica y de la atención médica centrada en la persona. De todas maneras, creo que eso se sublima teniendo satisfacción en lo que uno hace diariamente. Para aprovechar el tiempo que es escaso, tenemos 15 minutos para cada expositor. Invito al doctor James Appleyard, del Reino Unido, que va a hablar sobre el programa educacional de atención clínica centrada en la persona. El doctor Appleyard fue presidente del Person Center entre los años 2013 y 2017, vicepresidente de la Asociación Británica Médica, y actualmente miembro del World Medical Association. De manera que, doctor Appleyard, escuchamos su presentación.
Distinguished officers and friends, it is a great privilege to invite you to accompany us on our continuing journey through the world of personal medicine. Our journey starts with the person. Medicine is nothing without her. I don't know whether we could have some slides. Is somebody reading some slides on? Otherwise, I'll continue. Can anybody move the slide? I don't seem to be able to move the slide. Anyway, the journey continues as we saw from one medic through time and throughout successive ages. There were 8 fundamental elements that emerged. First of all, commitment. This is essential to the doctor-patient relationship. The second element is a relationship focus. Without the doctor-patient relationship, there will be no medicine. And thirdly, individualized care and holistic scope. Those are the first 4 foundational elements of person-centered medicine. And then we must seek the common ground for collaborative care and diagnosis. Sensitivities and people-centered systems of care. We have in our hands the opportunity, as Professor Rawaf said, of making major changes in the failing health systems. And it is by changing the situation, focused primarily on what the job they do, the targets, that we can actually change systems of care. And for this, we need our 8th important foundational element: person-centered education and research. So the purpose of the program is to spread understanding of these principles and to address strategies and procedures for person-centered care in terms of knowledge, skills, and attitudes. There are 3 components of the system, of the program. First of all, the first 3 articles relate to the general context of person-centered medicine. Secondly, communication, interviewing, and comprehensive diagnosis. And thirdly, care planning, shared decision-making in general, and health service organization in particular. The program emphasizes the centrality of the individual in medical practice and for a person and people-centered approach. Language used in patient involvement is important. Currently, the language in healthcare is confusing and controversial. Language from its values and beliefs, reflecting and shaping social perceptions in our relationships. The word patient is limited in its description. By definition, a patient is a sufferer, one who suffers physically, one who is under medical treatment. This implies lack of autonomy, passivity, and people use words to describe themselves to their relationship with their illness and disability, and can therefore have personal and emotional significance. So the current use of language, patients are labeled in different ways. They're not descriptive of a person, but of a relationship, and are never likely to reflect the wide diversity of each individual. That's why our prefix, person-centered, is so important. The program is a living document, and 3 further components are planned: personality and genetics, culture, and spirituality. And we look forward to you in South America for your involvement, and perhaps you may join with us and prepare a program particularly related to the needs of South America. I look forward to hearing. Thank you very much. I'm sorry nothing moved on. I hope people understood what I said.
Yes, of course. Thank you very much. The first is us. The next conference is by Dr. Kiki Agarwal, who will speak about enfrentamiento de la pandemia a través de comunicación centrada en la persona entre líderes de sociedades médicas de Asia y Oceanía. Es decir, un tema fundamental lo que nos ocupa, que es el problema de la comunicación. El doctor Agarwal es presidente de la Confederación Médica de Asociaciones de Asia y Oceanía, presidente de la Fundación Educación de la India y past president y presidente honorario de la Indian Medical Association. Doctor Agarwal, adelante, por favor.
Thank you, everybody. Thank you for the conference for inviting me. And I will be talking about some of the issues related to India and Asia. Am I?
Dr. Agarwal?
Yes. Am I okay? Am I audible? Am I audible
yes,
now?
Let's go.
Thank you for inviting me, Jim and others.
Yes.
And I will be talking about some of the aspects of Asian countries vis-a-vis person-centric medicines. So, greetings from Confederation of Medical Association of Asia and Oceania. Can I have the first slide, please? Yes. If I see the word scenario, you can see in the word there are 3 peaks. You can see the first peak in February, the second peak in around August, and the third peak is in around November. And so therefore the world is facing 3 peaks. Next. But if you see 3 countries, that is India, Argentina, and Poland, they are showing only single peak. So therefore 2 distinctive features are seen. All other countries are showing a double peak, but India, Argentina, and Poland are showing a single peak. Next. Now these are the top 10 countries mortality, and you can see the number of cases are different in various countries. Next. These are again the mortality patterns going back according to the number of cases. Next. So these are the world, Europe versus Asia versus the world. And you will see in Asian countries, the mortality is significantly lower than that of the US and the West. Next. Now, coming back to the person-centric aspect, COVID-19 is acute, means it can last for 9 days, the viral phase. From 9 days to 3 months is a post-COVID phase. After 3 months is either non-COVID or a long COVID. It is manageable because we know the treatment today. It is immunogenic because there are 2 responses, the early innate response and an adaptive response, which is a Th1 response. It is thrombogenic because it causes coagulation. It's inflammatory disease. It is notifiable, means contagious viral disease. So when we talk about this disease, if you want to reduce the mortality, we have to compare the results various countries. Next. Next. Can I have the next one? Now coming back to the Vedic philosophy. No, go back. Go back. If I go back to the Sankhya Yoga, which talks about various aspects of person-centric medicine, in our body we have 5 different types of movements. One is called a movement of the oxygen or the brainstem reflexes, which is my respiration and is called pranavayu. Apanvayu is the movement where we pass urine, stool and menses. Samanvayu are the GI movements. Udanvayu is higher states of consciousness, and Vyanvayu is cardiovascular movements. You will see here in this condition, we specifically get a condition called happy hypoxia. That means Udanvayu is intact, but Pranvayu is impaired. It also talks about there are 5 different places where metabolism or fire or inflammation can take place. It talks about Pachak, which is GI, Ranjak, which is blood, Sadhak, which is heart, Alochak, which is eye, and Bhrajak, which means skin. Therefore, a person can have these 5 different types of inflammatory conditions. And then he says, accumulation of fluid can occur in 5 places in the body. Avalambak is chest, Kledak is stomach, Tarpak is CSF, Bodhak is tongue, and Shleshak is joint. You will see in this particular condition, the third collection of fluid doesn't occur anywhere in the body. Metabolism is impaired and the ears are impaired. And according to Sankhya philosophy, that every person is different, therefore every person has a different symptom. You cannot generalize symptoms of this. You can mathematically calculate which patient is going to get what symptoms. Next. It also talks about 6 stages of a disease. The one is called accumulation, which is sanchay, that is the origin when the virus enters a cell. Then it is aggravation, that means there is a local inflammation. Then it starts moving, that means production of IL-6, and then it localizes to other 5 organs just described, and then there are symptoms of extrapulmonary or pulmonary. Next. So when we talk about treatment, treatment has to be person-centric. Why? Because viral behavior may be different from person to person. The inflammatory changes may be different from person to person. Some person may get a thrombotic complications, other may not. And somebody may have an early revival of organ, others may not. So therefore, treatment has to be decided on a person-to-person basis based on antiviral treatment, anti-inflammatory treatment, anti-thrombotic treatment, revival of organ damage, either alone or in combination. Next. When we talk about nutrition, so you cannot give them, everybody is the same nutrition. You cannot give them that this is one particular tablet, you take it. Every individual may have a selective vitamin deficiency. Somebody may have a selective zinc deficiency, mineral deficiency. Somebody may have innate immunity deficiency or disorder or adaptive immunity. So you cannot have all the persons having the same type of a nutrition. Nutrition has to be person specific depending upon what we are covering, the vitamins, the minerals, the innate immunity or the adaptive immunity. Next. Now remember, we treat the patient and not the disease. In a normal way, we treat the patient, but here we have to treat an individual patient and not the disease. So therefore, there cannot be a treatment which is fixed for all the diseases together. Next. Next. No, go back. No, there are some slides which are missing. Can I go back? Okay, so I'll spend some time here because I still have some time. So when we talk about the treatment of a patient person-centric, a particular patient may have, for example, people with loss of smell and loss of taste, they don't become serious at all. They will recover. Some people from loss of smell and loss of taste will have a perverted taste. Others may have a non-perverted taste. Some people will have loose motions. Some people will present only with headache. Some people will present with serious pneumonia. Some people may only have a loss of simple gastrointestinal problem. Now, in a family of 15, you can have all 15 people having different manifestations. So you can't give them the same treatment to all of them together. Why some people suffer more will depend upon the type of immunological reaction. So some people will have different types of symptoms, they have different types of responses. So based on individual basis, we need to treat them. If the patient, so let's take an example in India, we have been able to reduce the mortality to less than 1% of symptomatic cases. In India, for every symptomatic cases, we have 90 asymptomatic cases. Those 90 of them are recovering of their own. That means India today has almost 10 million cases. So for every one patient, there are 90 asymptomatic cases. All these asymptomatic cases behave differently. Their symptoms may be different, their immunity may be different, their treatment may be different. So what we have seen in India is, number one, children less than 6 years need not be treated. Number two, children between 6 years and 12 years, they need observation, they will become all right by themselves. Children between 12 and 20 years, their mortality is very, 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 very low. Fourth, during menstruation, we have seen symptoms are becoming less. Fifth, we have seen in menstruating women, the symptoms are in a menstruating period of women, that means premenopausal, the mortality is very, very, very low. Another finding we have now seen is in India that all those patients whose baseline high sensitivity CRP is more than 2, because we say high sensitivity CRP is a marker of inflammation. So all those patients whose baseline CRP is high sensitivity C-reactive protein is more than 2, they are likely to get more complications. Up till now, we have been talking about a program which is, so if you want to control inflammation in the body, in doctors we have seen the high viral load is very, very, very high. In doctors, we have 700 doctors who died of COVID with a very high viral load. So in every patient, we try to find out, is the viral load high? Is the inflammation high? Is the thrombogenicity high? Is the organ damage high? And depending upon the prediction of a case-to-case basis, you may find a different treatment. When we have gathered these information,
excuse me, we have 1 minute. Well, we have 1 minute only.
Yes. So I'm going to end by saying that person-centric treatment of COVID-19 is much better than a broader symptoms based on what vitamin, what mineral, what innate immunity, what adaptive immunity, and what type of inflammation he is suffering, which organ he is having the inflammation, which thrombogenic picture, etc. Thank you.
Thank you, Dr. Wall. It's very interesting, your exposition. Es muy interesante escuchar la confrontación de distintas culturas, distintas formas de ver los mismos problemas y cómo pueden tener múltiples soluciones. La próxima exposición será complementaria de las anteriores. Hablamos sobre educación, se habló sobre comunicación, y ahora vamos a entrar en el tema del diagnóstico centrado en la persona. La conferencia estará a cargo del doctor Isam Salum, que es un experto en neurociencia, trabaja en el Departamento de Neurociencia y es director del Instituto de la Universidad de Texas. Doctor Salum, por favor, adelante.
Thank you very much.